Hello, everybody. Today we will do the review for Pharmacology 1 for the final exam, and we will talk about the main topics overall that are really high yield for NCLEX, HESI, and material that I would like you to keep in mind all the time. All right, so let's start. We will talk about the review final exam. We're going to talk about all these topics that you already know by your syllabus. And one thing before how to take exams in general, not about the final, but in general. First of all, what I want to say is that NCLEX is a safety exam. So everything that is about safety patient, okay? And when you are doing, when you talking about safety patients, you need to know what can make harm to the patient, what can hurt the patient, and what not to do in order not to hurt the patient. For this, you need to talk about, we were going to talk about nursing considerations. And for that, you need to know the side effects and the contraindications. So when you want to talk about the side effects, just to remind you, is what is the effect of the drug? Effect of the drug. This effect of the drug, for example, we are going to talk about milk magnesium that is used for what is going to produce as a side effect is diarrhea, right? So if you use milk magnesium for treating, for example, gastric acid, if you going to remember, magnesium is going to be depressor. And mostly what the side effect is going to happen is going to be diarrhea. So what is the implementation for this? And how we are going to evaluate. So there's many things that you need to remember about nursing considerations, side effects, contraindications, the implementation, and how to evaluate the effectiveness of the medication. All right, so for example, digoxin. Digoxin is used for slow the heart rate for people who have arrhythmias and slow the heart rate. So if you have high levels of digoxin, what is the side effect? The side effect will be let's put it this way, the exaggeration of the action of the medication. In this case, it's going to slow down the heart rate because it's used for antiarrhythmics or as antiarrhythmic. So what could happen is the bradycardia, asystole. Okay, and what are the nursing considerations in this case? What is important? So you don't need to remember every single detail. Just remember in this case, what is relevant is to know about an antidote, the digoxin, that is the Digivan. So that is an example only. And here we have that main thing, all medications we are going to see today, they are going to be metabolized by the liver. Most of the medications are being metabolized by the liver. And mostly of the medications are going to be excreted by the kidney. So what happens is if you have the liver damage, the medication will not be metabolized. And most of the cases, what they are going to happen is accumulation of the drug producing toxic levels. And the kidney, when it's not working, what is happening is that all the metabolites cannot be eliminated. So toxic levels of both cases are going to happen when you have a medication where with the patient who have liver failure and or kidney failure. All right, so let's start with the first topic, and is the anesthetics. You know that the last lecture is where we are going to have more of what we are going to ask. Why? Because we didn't have a quiz about this, so mostly it's going to be focused on that. So we have the anesthetics are drugs that reduce or eliminate pain by depressing the nervous function, the central and peripheral nervous system. And we have the general anesthesia, we have the local anesthesia, and balanced anesthesia. So those are the three main divisions. General anesthesia, you lose consciousness. You decrease the reflexes. Local anesthesia, you are not losing consciousness, okay? One thing that I want just to point out very much, please, open eyes, open ears here, is the anesthetics in general. You think about, for example, anesthesia for surgery, right? We have problems with anesthesia administration or effects on the patient, especially in patients who are obese and patients who are old. Elderly patients and very young patients are going to be affected by the anesthesia. So especially remember elderly people and patients who are obese. Okay, so talking about general anesthesia, we already know that it's a complete loss of consciousness and reflexes, and we have different type of general anesthesia. We have the inhalers, we have the parenteral anesthetic by IV, and we have some coadjuvants for anesthesia. For example, they are going to administer corticoids, NSAIDs, etc. But we are going to focus on these two, the inhalation and the parenteral anesthetics. Okay, so let's talk about the general anesthesia. So the general anesthesia is a patient who is totally have under analgesia, so no pain, going to lose consciousness, and they are not going to have some. They're going to have some loss of memory too. Regional, the patient can be awake. For example, somebody having delivery, you have the epidural, and the epidural is the injection that is going to be through the spinal cord, and what is going to anesthetize is the area, for example, from the abdomen to the below the abdomen down to the pelvis. So that is regional. Okay, so we need to remember that there is minimal sedation. Minimal sedation will be, for example, diazepam. Those are minor tranquilizers. What I want to focus here is in the moderate sedation. Moderate sedation mean we have the midazolam that is even more, is 2 to 3 times more potent than the diazepam. And what we are going to use this is because we want the patient to be sedated but no unconscious. And that is being used for example, endoscopies, colonoscopies, that we don't need actually to make the patient sleep or lose consciousness. So that's why we are going to give this moderate sedation. Deep sedation, we have the nitrous oxide and the sevoflurane. So those are for deep sedation. We have moderate sedation, the propofol, and these what are going to do is induce or maintain anesthesia as part of balanced anesthesia. So they can be according to the dose. If you give in lower doses, they can have a sedative or hypnotic, make you sleep properties. But if you give in higher doses, they can produce a major sedation. All right, so in addition to the anesthetics, especially in surgery, we have the general or regional anesthesia. We are going to have some anticholinergics, okay? Anticholinergic, succinylcholine, that is being used to relax the muscles of the area of the body in order to make the surgeon manipulate the operate more comfortable without resistance of the patient. Okay, so what is doing this succinylcholine? So imagine you have anesthetic, general anesthesia. You are unconscious. You need to relax in addition to that, and for that they give you succinylcholine. The antidotes for this is going to be the anticholinesterases. Okay, anticholinesterase is an enzyme who destroy the acetylcholine. So that is going to be the opposite of the effect of the succinylcholine. What I want you to remember, succinylcholine is anticholinergic, and this is going to do the antidote, the anticholinesterase. What it's going to do is to increase the levels of acetylcholine. Nitrous oxide is the laughing gas, is the weakest of all the anesthetics. Ketamine is used for as IV IM and is a rapid onset action. They have less side effects and the patient recover very fast, about probably 1 hour or 2 hours after receive the ketamine, and they can lead into general anesthesia and moderate sedation. So moderate sedation in minor doses, low doses, and more higher doses, general anesthesia. We have the precedes. Precedes is the dexmedetomidine, sorry, and used for sedation. And what is important about this medication is being used for patients who are under mechanical ventilation, especially in the ICU. They are going to be short duration, but what I want you to remember from this is that dexmedetomidine is the precedex that is used for when the patient is going to be intubated with mechanical ventilation. Okay? All right, so now let's start this. General anesthesia is going to have one major side effect that we need always to be careful. That is happening during the general anesthesia or after the anesthesia. This is called the malignant hyperthermia. Malignant hyperthermia. I'm not going to talk about too much about that. I'm going to just go straight to the point. And first of all, when you have a patient who is in the post-op, suddenly they can start reacting and having some signs and symptoms of malignant hyperthermia. This increase the temperature more than 104 Fahrenheit, muscle contractions. They can have tachypnea, so the respiratory rate increase, tachycardia, muscle rigidity, life-threatening emergency. So they can actually have some contraction of the diaphragm and produce some, the patient can die from suffocation. What is important about this is two things. Malignant hyperthermia caused by anesthesia, number one. And number two, the antidote. Please, the antidote is the dantrolene. Dantrolene. Don't get confused with the naloxone or naltrexone, that is for antidote for opioid. Dantrolene is not for opium. Dantrolene that you see in the screen is used for malignant hyperthermia. All right, so we have local anesthesias, we have topical or parenteral, so cream solutions is topical. For example, when you're going to apply some Foley catheter, they have some anesthetic, they can produce a decrease of the sensation of the friction of the Foley through the urethra. We have parenteral, we have, for example, there's different type of injection. One is, for example, when you are going to do the sutures of so by injection, you have a cut and you're going to receive lidocaine with adrenaline, lidocaine and adrenaline. So that's what we explained in the last class. So lidocaine plus adrenaline is used in order to make the lidocaine stay longer in the tissue where it's applied. All right, so one of the local anesthesias that can produce, for example, regional anesthesia is when you have the epidural, when you are going to have a baby, for example, and they are going to produce one side effect is about 70% of the patients who has this puncture on the spine, when they put the anesthesia, is going to produce a headache. And that's why it's called the spinal headache, spinal headache. All right, so nursing considerations, we have the pre-anesthetic. So you need to check all the history of what happened in the previous surgeries. If they have previous surgeries, allergies, alcohol, if they're using opioids or some other drugs. The assessment is going to be during the pre and the intra and the post-operatory. So you need to check all the vital signs as a baseline. With the AKG, with any labs of the liver, etc., etc. And that is what you need to think about is the what is the basal line of the patient, and to compare how the patient is doing during the surgery, but mostly likely you're going to do after surgery, post-surgery, because the nurses that are going to be in the operation room are the ones who can do the vital signs. But mostly the patients are coming on your hands when is in the post-operatory. All right, so nursing considerations in the post-anesthetic. So we need to teach the patient about the post-operatory turning, coughing, and deep breathing. For example, coughing is have a pillow on the abdomen, deep breathing in order to expand the lungs, and we need to watch for sudden changes on temperature, which can lead into malignant hyperthermia. What is the antidote for malignant hyperthermia? Dantrolene. All right, so let's talk about the antacids. We have, they're using for PUD, peptic ulcer disease, indigestion. We are going to talk about Helicobacter pylori, so I'm going to make a very brief summary of all of them. All right, so we have here antacids. Is the mechanism of action is to neutralize gastric acid. We have amphogel. I want you to remember that is aluminum here. We have the magnesium. What is important, the magnesium here. Malox, they have aluminum and magnesium. We have TAMs that are calcium carbonate, sodium bicarbonate, and the combination that we are going to see now. So we have the anti-H2. Anti-H2 mostly are located in the stomach and produce H2 produce the chlorhydric acid. So we are going to use, in order to inhibit that, anti-H2. And these guys are going to be ranitidine, cimetidine, and famotidine. Tidine, anti-H2. Okay, so we have another one that is the PPI, the protein pump inhibitor, that is the omeprazole, very famous now is the Prilosec. Prevacid is the lansoprazole, pantoprazole, prazole is PPI. We have the coating agents. Coating agents, they are going to produce a cover on the mucus of the stomach, and that the name is the sucralfate. We have the prostaglandins. If you remember the last class, we was talking about prostaglandins. They have many effects, right? One is local messenger for pain, for inflammation, for clotting, and for mucus. And that's what is doing this. Prostaglandins is going to stimulate, increase the levels of the prostaglandins who are making the mucus of the stomach more thicker. Prokinetics is regulate the GI tract motility. So the name is the metoclopramide. And what I want you to remember about the prokinetic means movement, is the extrapyramidal symptoms. Extrapyramidal symptoms. That is what we call the pseudo-Parkinsonism. Pseudo-Parkinsonism produce these extrapyramidal movements that are called extrapyramidal symptoms. They can lead into seizures. All right, so we have this chart that you already know, and we are going to continue with the side effects and what I want you to remember. Antacids, first of all, doing neutralized acid. We don't want to give in kidney failure. Please remember that. Kidney failure doesn't like magnesium, because in kidney failure, magnesium is not going to be eliminated. Magnesium is a high percentage of magnesium. I would say 95% of magnesium should be eliminated by the kidney. But if the kidney is not working, magnesium is going to stay in the body. And if magnesium is a depressor, your reflexes and you're going to enter into alterations of LOC. Okay, so we have side effects. Aluminum, constipation. And don't forget that. Magnesium, we have diarrhea. Okay, the treatment for magnesium, you already know that magnesium, you can assess the toxic levels of magnesium when the reflexes are down. And for this, we have a calcium gluconate, because calcium is going to promote the contraction of the contraction and the depolarization of the smooth muscle and nervous system. So please, if you have, if you give magnesium to a patient, they can lead in, and if they have kidney failure, they can lead into hypermagnesemia. So the patient is going to be totally lethargic with areflexia. So that means slow reflexes in all the body. Calcium carbonate, that is an antacid too, is produce the rebound hyperacidity. Rebound hyperacidity. So this guy is going to calm the gastritis, or the sensation of gastritis, for a few moments, and then start to the stomach produce more gastric acid. So I will not recommend it actually to take calcium carbonate as a first line. Sodium bicarbonate. Sodium bicarbonate is the Alka-Seltzer. Sodium bicarbonate is alkaline, and when you take in excess, this alkalinity go into the blood, producing metabolic alkalosis. Now, medication who decrease the acid. Anti-H2, please remember anti-H2. H2 is a family of H1, antihistaminic H1. The Benadryl, for example. What is main side effect is drowsiness and dizziness. So that is because they are very close chemical structures. They have similar activity. Remember, H1 are in all the body. H2 are in the stomach. So H2 produce gastric acid. We give anti-H2 to prevent the production of gastric acid. PPI, we have this. Mostly what we need to remember is the Prilosec, for example, or omeprazole, pantoprazole, lansoprazole, prazole, and these are mostly used to prevent stress ulcers, especially in the first 24 hours that the patient is getting into the intensive care unit, and especially the first 24 hours, and is used in cases of Helicobacter pylori. We have the coating agents, the sucralfate coating. Just remember what is the side effect: coating, constipation. We have the prostaglandins, that is the misoprostol. Prostaglandins, misoprostol is going to be used sometimes as abortive, and that's why it's contraindicated in the pregnant. What is doing misoprostol is to make the uterus contract. So that's why it's contraindicated with the with pregnant women. Prokinetic, we already talked about the extrapyramidal symptoms. You can add there pseudo-Parkinsonism. That is the same. All right, so let's talk about anticholinergics. And anticholinergics, you know, cholinergic effect is everything wet. Anticholinergic, everything is dry. Okay, so one of the main questions that they are going to ask you is about the side effect of the anticholinergic. Yeah, if you don't remember that, just remember that cholinergic is everything wet. So urinary incontinence, defecation, and secretion of the salivary glands. And the anticholinergic is the opposite. It's going to be constipation, urinary retention, and the dry mouth. Okay, so examples of anticholinergic, we have the atropine and the scopolamine. Just get familiar with these names. They are not actually going to ask you what is atropine, anticholinergic, cholinergic. No, they are going to tell you the atropine, that is anticholinergic, what could be the side effect, for example. So here we have, I just create some mnemonic here. The anticholinergic is going to have some increase of temperature. So hot as a hell, blind as a bat, that is going to produce mydriasis, dry as a bone, dry mouth, dry eyes, decrease sweat. So dry eyes, what is telling you, you can translate that into blur eyes, right? Blur eyes, or blur vision, sorry, blur vision. So that happens when you have dry eyes. Red as a beet, flushed face, so red face is red. mad as a hater, so that is delirium. So this is in addition or some of the effects that are the anticholinergic or side effects. All right, so antidiarrheals. Let's talk about antidiarrheal. Antidiarrheal, we have the bismuth subsalicylate, that is a Pepto-Bismol. The other name is the kaopectate, and that is being used for traveler's diarrhea. So it's very common to call it this way. So what we need to remember here is the subsalicylate. Salicylate means that they have acetyl salicylic acid. That means aspirin. And that can produce some, for example, increase of the activity of the warfarin or anticoagulants. We need to be careful. A patient who is a young patient, less than 18 years, with a viral infection, high fever, they can, if they receive aspirin, is going to produce the Ray's syndrome. Ray's syndrome is an inflammation of the nervous system. So, but you are not aware, if you don't know that the Pepto-Bismol, his components, they have some aspirin. So you need to prevent that in this kind of patients. So it's going to produce blue gums that is typically questioned all the time, darkening stools. So because they produce some bleeding on the GI tract, and that produce some darkening of the stools, dark stools. All right, so active charcoal is they are going to be used for some when some patient is taking some medication and you want to have gastric lavage, they are going to just use charcoal, and they can be used too as antidiarrheal because it's absorbent, so it's not going to let much fluid going out. So that's why it's going to be used as antidiarrheal. All right, so we have another one is the anticholinergic. Please open eyes, open ears with this, the belladonna alkaloids and opioids. So the belladonna are anticholinergic. So that means that, you know, cholinergic make contraction of the muscle. Anticholinergic is going to be the relaxation of the muscle. So in this case, what is going to happen is that the diminish of the motility of the GI tract. So the peristalsis go down. And diarrhea, what is doing diarrhea is increase the peristalsis. So antidiarrheal, anticholinergic in this case, is going to decrease the peristalsis. We have another thing that we need to really be careful here, the opium, tincture or codeine with the loperamide. Loperamide is what we call the Imodium, very common in the OTC, And what is important about this, even though that is a derivative from the opioid, do not cause dependence. So an easy way to remember is that Imodium we have as OTC, right? If that could be dependence or make some entertainment effect, let's put it that way, there will be, everybody will be, mostly Imodium will be out of the shelves, right? So we have another medication, this is the Lomotil, the phenoxylate and atropine. What is atropine? Is anticholinergic, and this is an opioid. So they combine the effect of the opium and the anticholinergic. Is the Lomotil. You know, the opium they have, number one is produce the depression of the respiratory rate, 1, 2, 3, 4, and 5 is going to be the constipation, right? So, but these medications do not produce actually dependence or addiction to the patients. We have probiotics that mostly is used when somebody has some diarrhea post-treatment of antibiotic, for example. Probiotics will stimulate the division, multiplication of bacteria in the flora, so they can compete with the C. diff. So C. diff will not develop or will not grow. All right, so another open eyes, open ears here, please. So antidiarrheal, never use with abdominal pain, because diarrhea sometimes is a mechanism of defense of the body. If you have some inflammation, you have some infection, This infection produces irritation of the mucus of the intestine. So, and the intestine trying to just get rid of that. So if you block that, the infection stay inside. So it's going to be actually worse. So any abdominal pain, especially that you don't know what is the cause, don't give laxative, not even antidiarrheal. So no antidiarrheal, and we will see in the next slides that we cannot do any laxative. All right, so in case of abdominal pain that we don't know the cause. Okay, so we have antiemetics. The antiemetics, you know the definition of antiemetics, and the mechanism of action is the blocking the vomiting center. Blocking the vomiting center is located in the brain stem. And there is many other substances that can produce the, for example, histamine, for example, serotonin. We have many other substances, dopamine, that can actually lead into stimulate the nausea and vomiting. So we are going, I have here the summary. We are talking about nauseous. Scopolamine. What is scopolamine? Anticholinergic. We have the Dramamine or the diphenhydramine, antihistaminic H1. We have the prochlorperazine, the droperidol, that is antidopaminergic. So it's going to decrease the dopamine. So too much dopamine can produce nausea. Metoclopramide is a prokinetic that is going to have the same effect but in different way, block the dopamine. We have the neurokinin that is coming from areas close to the cortex of the brain. For example, you have you smell something that is not a nice smell, you start to have some nausea, right? And that's because it's going to produce the neurokinin. Neurokinin is triggered out sometimes spontaneously for different reasons, and that we are going to use this medication in order to stop the neurokinin and stop the stimulation of the center of nausea and vomiting in the brain stem. That is called the aprepitant. We have another one, the serotonin blockers. Serotonin blockers. Serotonin stimulate the brain stem, producing nausea and vomiting. This is very common. It's the most common use for nausea in chemotherapy. So centron, centron, centron. And one thing, the patient, for example, is having nausea and vomiting for some medication that is intractable. The patient is not stopping having nausea and vomiting. And when the previous medications are not going to work, we have the dronabinol. It's the marinol that is a derivative from where? From marijuana. All right, so I'm going to review again. Scopolamine is used for motion sickness. You go to a ship, to a cruise, whatever, they are going to use scopolamine in patches, and they are going to last 3 days. So please, I'm going directly to the point. Scopolamine. We have the diphenhydramine, the Benadryl. As you know, if you take Benadryl, what happens? You become drowsy, right? And they can be used for motion sickness, for example, and sickness. And one thing that I need to point here is the hydroxycycline. Hydroxycycline is actually no IV. It's very common to ask that because there is a lot of medical errors here. So hydroxycycline is not going to be IV. Okay. Then we have the antidopaminergic. This is the prochlorperazine, produce drowsiness and pseudoparkinsonism. Of course, if you know that the mechanism of action is to decrease the dopamine, you know that dopamine is low when you have Parkinson, right? So if they are going to block, in order to block the nausea and vomiting, because dopamine stimulates the center of nausea and vomiting, you have low levels of dopamine produce pseudo-Parkinsonism. It's not Parkinson, it's pseudo-Parkinsonism because as soon as you stop taking the medication, the pseudo-Parkinsonism or the extrapyramidal syndrome, right, it's the same, are going to stop. Metoclopramide is the same. is Reglan. It's mostly used as a post-operative, and they can lead into pseudo-Parkinsonism. Why? Because this guy decreased to the levels of dopamine. All right, so that is about this part. Let's keep going. Let's talk about antifungals. Antifungals, what I want you to remember is the amphotericin, nystatin, ketoconazole, the fluconazole, voriconazole, and the caspofungin. Okay, so fluconazole can be used as a single dose of vaginal yeast. Open eyes, open ears there. And what we need to recommend the patient is not to have any intercourse until the medication is completed. Otherwise, it's going to be transmitted all the time. So, so that's why they need to just any vaginal yeast. If they take 1 day or 7 days treatment with other medications, you need to first finish all your treatment. Voriconazole, remember nasol, or azoles, and voriconazole can produce arrhythmias. So we need to have careful with patients who have using antiarrhythmics. Okay, one big thing is all the ketoconazole, itraconazole, fluconazole, voriconazole, azole. So they are going to just produce an increase of effect of the warfarin or anticoagulant effect. Caspofungin, very common to talk about this, aspergillosis. Aspergillosis is a fungus that is mostly happening in patients who has immune defenses down and especially attack the lungs. Caspofungin is used as a last source because it's the newest antifungal that we keep it until previous medication do not make effect. All antifungals produce gastritis, so you need to take it with food. Okay. All right, so let's go here. The main thing that we need to talk about is amphotericin. Amphotericin is a systemic antifungal. Okay, and we will see what are the side effects of amphotericin because it's always coming. Fluconazole can be used as single dose vaginal yeast. Voriconazole is used for aspergillosis, a fungus, and be careful with the arrhythmias. And caspofungin is for aspergillosis. Between voriconazole and caspofungin, the one who is more effective is the caspofungin in aspergillosis. All right, so here we have the amphotericin side effects. A means no mix with antibiotics. M, malaise. P, pre-medication because the injection is for systemic severe fungal infections. So the patient is having nausea and vomiting, so that we have some pre-medications to stop these side effects. Hypokalemia. So amphotericin can lead into hypokalemia. Time of infusion, more than 60 minutes. They can produce infiltration and nephrotoxicity. And we have another open eyes. Here is the lipid amphotericin B. Lipid amphotericin B is going to have less of the side effects that we just mentioned before. Lipid amphotericin B. All right, so here very fast, the superficial mycosis, we have the griseofulvin for ringworms, Lamisil for the onychomycosis, and let me see, we have a picture here of onychomycosis. Yes, that is the onychomycosis, I'm sure you remember that. And mostly the antifungals, when they go into parenteral administration, they can produce nephrotoxicity, hepatotoxicity. The superficial antifungals are going to produce mostly the rash, skin rash. Okay, all right. All right, so here we have again, so the ketoconazole is used for systemic and can be used for superficial. Okay, all right, so But from this slide, what I want you to remember is this, the nystatin. Nystatin is used for thrush, candida. The thrush is candida albicans. So nystatin can be given in the lozenges, and they can actually get rid of this fungus on the oropharynx. Antiemetics, Pirantel, diarrhea, mebendazole, myelosuppression. Okay, so these antihelminthics, that is for antiparasites, Pirantel and mebendazole, are going to have this side effect. This is the urine smell as asparagus. Okay. Okay. All right. So we have the antilipemics. And talking about antilipemic, we have the statin, BABA, niacin, or omega-3, fibric acid. All right, so for talking about antilipemics, I want just to make a brief summarize here, and open eyes, open ears here, please. One of the most important is the niacin, that is the vitamin B3, right? And what is the side effect is the produced flushing of the face and pruritus. We need to remember that the antilipemic means to decrease the cholesterol levels, and you have the HDL and LDL. You must know what is HDL, that is the good cholesterol, and the LDL, that is the bad cholesterol. Another important thing is about BABA. BABA is the bile acid binding agent or sequestrant. That is the cholestyramine that decrease the absorption of the fat-soluble vitamins, the A, D, E, and K. Okay, so fibric acid is mostly for decrease the triglycerides. Especially we use this in fertile age women. And the king or the queen or whatever you want to call is the statin here. Is the strongest antilipemic. And you need to remember one word, myopathy. So statin can produce the rhabdomyolysis, right? Rhabdomyolysis, that means that you have destruction of the fibers of the muscle. So, and just remember that we have this main thing about the antilipemics, okay? Questran, cholestyramine, what is BABA? Lipitor, atorvastatin is the Lipitor. Okay, mostly we give it Lipitor at night because that is going to inhibit the production of cholesterol. All right, so talking about antimalarial, malaria, we have the parasite that is actually a protozoario, that is the malaria, getting to the red blood cells. This plasmodium, that is the parasite who produce malaria, this plasmodium, when they go inside the red blood cell, where it's going to reproduce, we use the primaquine. And when they're outside of the red blood cell in the circulatory system, we are using the chloroquine. All right, so talking about the Parkinson. Talking about Parkinson, you already know that there is many medications that we are going to use for this. We have the MAO inhibitors. The MAO inhibitors. MAO is the L-Depril. If that is not going to make effect, you're going to use the dopamine. And when it's not making effect, you use the levodopa plus dopamine. And at the end, you're going to use another medication that is called the COMT. So levodopa, dopamine, and then COMT. So those are the 1, 2, 3, 4 steps for treatment of Parkinson. What is doing this anti-Parkinsonism increase the levels of dopamine. You know, the Parkinson is controllable, but not if we cannot cure Parkinson, and is the imbalance between the acetylcholine and the dopamine. If taking MAO inhibitors, that is the L-Depril or selegiline, don't eat food with tyramine. Tyramine is going to be contained into yogurt, cheeses, wines especially, and what it's going to do is to lead into hypertension crisis. It can be into death. All right, so talking about the antivirals. Antivirals, what I want you to remember is the main names. In general, these antivirals produce hepato and nephrotoxicity and photosensitivity when the antivirals is applied as a cream, as an ointment. The long-term side effects of antivirals are going to be oil, osteodystrophy, so that means the osteoporosis, one of the things. I is insulin resistance, and the L is the lipodystrophy. Okay, so we have Ribavirin, that is one of the, is used for the for, for the for respiratory syncytial virus. The RSV, respiratory syncytial virus, is given in the form of aerosol. Why? Because it's easier, because mostly these respiratory syncytial virus are going to affect very young kids, less than 4 years old. So it's difficult to give medication, so aerosol is easier in this case. Oseltamivir is part of the SAROs, C-A-R-O, that is used for influenza virus. Okay, so what is SARO? I want you to remember, it can be taken within 2 days of the onset of symptoms. It can be taken up to 2 days of the onset of the symptoms to be effective. More than that, this medication is not going to affect. So it's not going to cure. There is no antiviral who cure from the viral infection. What is going to is to decrease the time of the process. Cytomegalovirus is the ganciclovir. Ganciclovir. It's a gangster, right? Remember? And we have bone marrow suppression. So bone marrow suppression, BMS, means that you need to watch for infections, bleeding, etc. Okay, aciclovir. So what we need to know about aciclovir is, first of all, they produce transient burning when applied topically. Okay, so open eyes, open ears, transient burning may occur with topical application. Aciclovir should be taken in IV, should be given more than 60 minutes. Zidovudine. Zidovudine is for HIV. Zidovudine is one of the 3 medications that the patient needs to take every day. And 3 medications because they can produce resistance if you give only one of these antivirals. And what the main thing that we need to remember is that bone marrow suppression. Bone marrow suppression. That can lead into bone marrow suppression. Bone marrow suppression, the 3 lines. It could be red blood cells, or and platelets, or and the white cells. All right, so this mnemonic is just to remember the all the pathology that we was talking. All right, so I just point what is really important. Bone marrow reabsorption inhibitor. So that is a part of women's health. And we have the biphosphonates. Biphosphonates, what is doing is to inhibit the reabsorption of bone. So that means inhibit the loss of calcium from the bone. What is important about this is that you need to take it, and open eyes, open ears, biphosphonates need to take with a lot of water, 6 to 8 ounces of water. Why? Because it can produce a very severe gastritis and produce some esophagitis. So it can produce ulcers on the esophagus. So that's why this medication need to take with a lot of water. All right, so digoxin. Digoxin is, as you know, is negative chronotropic, means chronotimes decrease the heart rate. Positive inotropic, positive means increase the contractility of the heart. So these patients are going to, patients who are having arrhythmias are going to use negative chronotropic. Patients who are going to have heart failure, they get a benefit from this property, positive inotropic. So I talk about digoxin because this is have a very strong interaction with the diuretics. Diuretics who are going to lose potassium. All the diuretics except the potassium-sparing diuretics, the triamcinolone amiloride and spironolactone, all the rest of diuretics can make loss potassium. And when you have low levels of potassium, there is high risk for digoxin to be toxic. What is the toxicity of digoxin? If the heart rate go down, that can produce slower, even more, the heart rate producing cardiac arrest. So for that, you need to have the apical pulse. Apical pulse, you put the patient in the prone or lateral oblique position, lateral oblique position on the left side, and you check with the stethoscope the cardiac activity. If there is more, is less than 60, you need to stop the medication. You need to ask for potassium levels, and in 1 hour you need to repeat the potassium. And if the potassium is still low, you need to just call the doctor immediately. The antidote, you don't need to remember the antidote at this moment because that is actually pharmaco 2. Cholinergic agonists. Cholinergic. Remember, this cholinergic produce contraction of the cholinergic effect. Acetylcholine, wet, saliva, urination, defecation. And we have two receptors for this acetylcholine, the muscarinic and the nicotinic. The muscarinic is the effect that we want to have in cholinergic medication. And that is happened when you give a cholinergic agent with lower doses. But if you increase the doses of the acetylcholine or cholinergic agonist, that is going to stimulate the nicotinic receptors that we don't want to make happen. So mostly the muscarinic is going to found in the glands, heart, smooth muscle, and the nicotinic receptor is going to produce contraction of the skeletal muscle, and we don't need that. So that's why we need to just be careful. Muscarinic receptors are the those that we are looking for this effect. All right, so cholinergic agonists. Cholinergic agonists, we have the beta-nicol, cholinergic again, contraction, right? We have the, first of all, acetylcholine that we already know very well. But acetylcholine in medical practice, it doesn't have that much use. Why? Because they have high activity in the nicotinic receptors. We have more specific medications that are the beta-nicol, carbachol, cimetine, and pilocarpine. So what is doing the beta-nicol is selectively stimulate the urinary and the GI tract, especially the urinary tract when you have, for example, a retention of the urine, because the urinary bladder do not contract, you are going to use the what beta-nicol. Carbachol is similar at the beta-nicol, but lasts longer, like 2-3 more hours. Cimetine is used for Sjögren's syndrome. Sjögren's syndrome is characterized as a collagen disease that produce dry eye. They can produce arthritis and can lead into urethritis. So in this case, we have dry eye Sjögren's syndrome. That's all I want you to remember. Sjögren's syndrome is dry eye. So dry eye, we are going to use cholinergic agonists that produce the way the dry get wet, right? So tears. Pilocarpine is used for glaucoma. Glaucoma is going to decrease the intraocular pressure. How is going to decrease the intraocular pressure? Increasing the exit or the outflow of the aqueous humor. All right, so here we have indirect acting. Those are they are going to be used. This cholinergic agent, they are going to be used for myasthenia gravis. myasthenia gravis. What is myasthenia gravis? It's an autoimmune disease that destroy the NMJ, so the neuromuscular junction. So the muscles do not contract, so you have flaccid paralysis. And it's dangerous because they can produce paralysis of what? Of the diaphragm. So we are going to use this hydrophonium, physostigmine, neostigmine, pyridostigmine used for mostly for myasthenia gravis. What we need to remember here is they need to neostigmine is the for maintenance and of the treatment of the myasthenia gravis 20 to 30 minutes before meals because that is going to improve the swallowing. So the muscles are able to contract. You need muscles to contract when you are eating, when you swallow, peristalsis. And that's why we need to give it 20 or 30 minutes before. We have Alzheimer. The Alzheimer is a decrease of the acetylcholine. Acetylcholine in the central nervous system produces the alertness, the focusing of the patient. The acetylcholine that is in the central nervous system, but in the peripheral nervous system produce what we already know, the contraction of the smooth muscle, striate muscle, and the cardiac muscle. Okay, so for this, we giving Alzheimer have low levels of acetylcholine, so we have a medication called the donepezil that is going to increase the acetylcholine and improve the signs and symptoms. Okay, so here we have the difference between cholinergic and we have cholinergic contraindications. For example, COPD. COPD. Of course, if you have COPD, chronic obstructive pulmonary disease, you have a lot of secretions and it's difficult to breathe. The gas exchange is going to go down. And if you give cholinergic that is wet, means more mucus, more saliva, is going to make it worse. Same for asthma. Cholinergic crisis is when you have too much cholinergic acetylcholine, and that can lead into hypotension. Hypotension. That is main important thing about the cholinergic crisis. All right, so let's talk about diuretics. Diuretics, we have we have thiazides, potassium-sparing, loop diuretics, and osmotic. All right, so the first line, let's make it very simple. Thiazide, first line for treatment of hypertension, are the small glands. So they produce loss of sodium and potassium, but not as much as the loop diuretics. Loop diuretics are the big glands. Those are produced the elimination of a lot of sodium and potassium. Okay, so what having in common the thiazides and loop diuretics? Mostly everything. But what is a difference between them is the loop diuretics have more strong effect and the thiazides more or less or minor effects, okay, compared to the loop diuretics. In addition to this, what are doing these guys are going to lose sodium and they are going to lose potassium, thiazides and loop diuretics. So you can have hypokalemia and hyponatremia. Another thing is that these two guys can produce hyperglycemia, and these two guys, if somebody is allergic to sulfas, that is an antibiotic, they can actually produce reactions with the thiazides and loop diuretics. Loop diuretics, in addition, they can lead into tinnitus. Tinnitus means a ringing of the ear. And one thing, all diuretics in general, no matter which one, can lead into hypotension, okay? Hyperglycemia, because the potassium is eliminated, okay? And the potassium is needed to enter into the cell. So the glucose cannot get into the cell with low levels of potassium in blood. And that produces high levels of glucose, hyperglycemia. All right, so let's keep going. We have the names, please. You must remember this. Potassium-sparing diuretics, what it's doing is eliminate sodium and retain potassium. Okay? So what foods we have high rich in potassium? Number one, banana, orange, and apricots. Don't forget that, never, please. Banana, orange juice, and apricots. So highest level of potassium. So we have triamcinolone, amiloride, and the spironolactone. Loop diuretics, we have the phytobum, we have furosemide, etaclinic acid, torsemide, and bumetanide. One thing I want to tell you about potassium-sparing diuretic we use for ascites when you have liver problems. Why we use in liver problems? Because this potassium-sparing diuretics is less hepatotoxic. Loop diuretics are more hepatotoxic. All right, so here we have the thiazides. What is doing is all these side effects. I just create this mnemonic: hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. So the hyperuricemia is commonly happen when you have loop diuretics and or the thiazides. So they are going to accumulate uric acid in the body. So if you have, for example, in the long run using months of diuretics, you can start having some pain on your feet, on your hand, in your fingers, and that is because the accumulation of uric acid in the joints. All right, so here we have, let me see here, 21. Cytokines. So let's talk about the biological response modifying drugs. For this, I want to go straight to the difference between them. Here we have. So hematopoietic drugs. Hematopoietic drugs are the ones who can increase the red blood cells, or they can increase the platelets, or they can increase the white cells. We have IF is the interferon, IL the interleukin. Those are communication. So interferon is going to interfere with the multiplication of the viruses. The interleukin is the communication between lymphocytes. Interleukin, white cell leukin, so white lymphocytes. So, and that is making, they're going to mark the cells who contain virus inside the cell to be destroyed. MAPs are the monoclonal antibodies, and the DMARDs that are going to be the use for arthritis. So let's make a summary here. All of them are going to have flu-like signs and symptoms. Flu-like signs and symptoms. If you see, I put all the signs and symptoms similar in all of these. Myalgias, bone pain, that is not important. They're not going to ask you in the NCLEX. So you see that they have similar side effects, but what is the difference between them is few things. All of them have flu-like. The MAPs, the monoclonal antibodies, are going to have hypotension. The rest, hypertension. Hypotension, the monoclonal antibodies. And one more thing is that the interleukin produces the capillary leak syndrome. Open eyes, open ears, please. Capillary leak syndrome, when you increase your weight more than 5 pounds in a week, or more than 2 pounds in 2 days, that is what is happening. So the capillary bed starts to dilate and start to escape fluid into the tissue, producing a generalized edema. And that's what we need just to remember. All right, so the DMARDs that we just previously saw is being used for, one of the most common is the methotrexate, and they use for arthritis. They can produce fatigue. The patient is very tired. They can depress the immune system. They can be used for other autoimmune diseases who are having inflammation. So DMARDs are going to be a double-blade tool, because if you give too much DMARDs, your immune system go down, you can die. The pain is gone, but you can die from infection, for example. All right, so we have the biological DMARDs that take action in 1 or 2 weeks. And we have the conventional that is going to take more than, conventional DMARDs is going to take more than 2 weeks. More than 2 weeks. Conventional DMARDs, more than 2 weeks effect, and the biological DMARDs, this is the Humira. The Humira is the last generation of these guys, are going to take action in about 2 weeks. That's all what we need to remember. Now, here in electrolytes. In electrolytes, you need to have, you need to remember the sodium and potassium. Just remember that. Sodium and potassium, the first signs, please don't forget that, open eyes, open ears. Any alteration of sodium or potassium could be high or low or lower. Always the first or the earliest sign is weakness. You feel fatigue, weak. So that is the first sign. Doesn't matter if it's hyper or hypo, natremia or kalemia. So weakness is going to be the main thing. Second, cramps. Cramps in the lower extremities in the potassium. Cramps in the abdomen in the sodium. They are going to affect the nervous system. Who first? The sodium. When you have hypernatremia or you have hyponatremia, they can actually affect the nervous system. So you have LOC. Meantime, in the hyperkalemia or hypokalemia, the main or the center of this balance is going to be the heart. So hyper or hypokalemia, heart. Hypernatremia or hyponatremia, nervous system. All of these four start with weak muscle weakness. Cramps on the lower extremities were in the alterations of potassium. Cramps in the abdomen, alteration of sodium. Problems in the central nervous system means LOC, sodium. And heart arrhythmias when you have problems with potassium. So the main cause of hypernatremia, you have same amount of solutes in sodium in the blood and you're losing water. So the sodium is very concentrated. So that is going to lead into hypernatremia. We have the hyponatremia. So what is the main cause of hypernatremia? Is going to be the dehydration, right? Dehydration. So let's go back. Dehydration, hypernatremia, okay? Then you have the hyponatremia. Hyponatremia, what could be a cause of hyponatremia? Diarrhea. Diuretics, right? We're talking about diuretics. Diuretics is going to lose that. So the treatment for this is going to be normal saline solution. We have hypertonic saline solution and fluid restriction. So in order to concentrate the sodium in blood. In the hypernatremia, you're going to try to eliminate sodium. So you can use diuretics in order to get rid of the excess of sodium. Hyperkalemia, so please remember this. Renal failure. Renal failure is important. Why? Because the potassium is eliminated in mostly all what is the way is elimination of potassium mostly is by the kidney. Parenthesis here, remember magnesium. Never give magnesium, magnesium sulfate, for example, in patients who have what? Renal failure. Because that can produce toxic levels. The kidney cannot eliminate, the body start to accumulate. Okay? Kayexalate for hyperkalemia. Let's talk about hypokalemia. So what is the main effect, what is the main cause of hyperkalemia? Renal failure. It can be other things like infections, excess of potassium with potassium sparing diuretics, right? Hypokalemia is mostly vomiting, okay? Laxative overuse. So people who are dependent of laxative, they are going to lose potassium. Okay, so what could be the first signs and symptoms of hypokalemia or hyperkalemia? You already know, is weakness. lower extremity cramps, and can be arrhythmias. Okay, so laxative, stool softeners. So we are going to see here the summary of that. We have the bulk forming that is used for long term. So you must know this. Is the metamucil and the citrusel, right? So those are over the counter, and mostly they can be used for as a long term. You need to take it with a lot of fluid. If you take just the powder, it's going to be like a ball and stay there and produce more obstruction of the GI tract. So you need to take with at least a full glass of water. We have stool softeners, right? That are actually to prevent, for example, when you're going to use stool softeners, when you have opioids, okay, the patient is taking opioids, and you start to think about ahead of time that the opium can produce number 1, number 2, 3, 4, 5, respiratory depression, and number 6 is going to be constipation. So you need to prevent with the stool softeners. We have the PEG, the polyethylene glycol, that is being used for example, colonoscopies. Before you have the colonoscopy, they give you this fleet of fluid that make you evacuate and clean all the colon. So it's free of fecal material. So in the colonoscopy, you can see better the lining of the intestine. We have this is very important to remember. We have here the magnesium hydroxide, is the milk magnesium. Remember, it's being used as antacid, right? And that can be used too as a laxative too. And that is the fastest that produce immediate relief, of the constipation. So we have a stimulant. We have the bisacodyl, the dulcolax. What is doing the stimulant? The dulcolax produce the irritation of the mucus of the intestine and produce increase of the peristalsis. All right, so please, here is the main core of what I was preparing for you guys today. All right, so narcotics. So we need to talk about some medications. We are going to talk about pain, opioids, and NSAIDs. All right, so one thing I want just to remember is number 1. Please remember this, pay attention. The difference between acute pain and chronic pain. All right, so 3 months, right? 3 months. That is number 1. Number 2, we have we need to remember that we have the NSAIDs, the aspirin, and we are talking about aspirin. We are going to talk about ibuprofen. And what is not NSAIDs, is not an NSAID, is the acetaminophen. So that's what we are going to talk right now. All right, so let's keep going. Open eyes here, please. We have a narcotic. When you're using opioids, they produce the tolerance. Orthostatic hypotension. The pressure go down. So you can have respiratory depression. This is the main thing. Respiratory depression, orthostatic hypotension, constipation, and they can lead into tolerance. What is tolerance? You take the medication now, it's not making effect, so you need to have more dose. And you increase the dose because you want to have the same effect, or you need to have the same effect. At the end, you cannot increase more because the respiratory depression is going to be really severe. So how we control that? With a respiratory rate. Less than 12, you need to stop the medication. Okay? So use narcotic antagonist is as the antidote, is the naloxone or Narcan. Okay, Narcan, and the other one is the naltrexone. So listen, there is 2 names here, naloxone and the naltrexone. Naloxone is the same to say Narcan. But what is the difference between them? The difference is that naloxone or Narcan is not PO. Naltrexone is PO. Okay, so but there is two of these drugs. The difference here between from the route. So you need to just to remember that. Okay. All right. So let's keep going. NSAIDs. We have the aspirin, etc., the Motrin, etc. And what they're going to do is the main side effect of these NSAIDs is gastric tract upset, dyspepsia. What is dyspepsia? Dyspepsia in the indigestion. That means gastritis. Gastritis produces irritation, inflammation of the mucus of the stomach, leading into nausea and vomit. They can produce bleeding, so they going to increase the effect of the warfarin, as you know, and they can lead into hepatotoxicity when you have high doses of this medication. Okay, tinnitus. Tinnitus is when you have salicylism. Salicylism means intoxication with NSAIDs. Tinnitus is the ringing of the ear that is actually cranial nerve number 8 who is being affected. We call ototoxicity. 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 Okay. All right, so let's keep going. So you already know pain 1 to 3 is we have Tylenol, or you can have the NSAIDs. Okay. Opioids plus NSAIDs, the Vicodin, Percocet, Excedrin, they are going to be for pain for 4 to 6. And that's what I want you to learn from this class, please. Combination of side effects when you have opioids and NSAIDs, you have lightheadedness, urinary retention, constipation, and itchiness. Lucy, right? Remember please that combination of the opioids and NSAIDs, the Vicodin, Percocet, Excedrin, Percodan, are going to have this side effect, Lucy effects, lightheadedness, urinary retention, constipation, and itchiness. All right, so aspirin, first of all, I don't want you to get confused on this, please, okay? Aspirin, we already talked about the difference between ibuprofen and aspirin. I want to go straight to the point here, is that this is the only, aspirin is the only one who lasts 4 to 7 days as anticoagulant. So they are going to decrease, is antiplatelet aggregation. So it's going to stop the aggregation of the platelets. That is doing the aspirin, okay? The other NSAIDs, they have little bit or none of these antiplatelet effect, okay? The maximum dose that you have is 4,000 milligrams of aspirin. For acetaminophen, the maximum dose is 3,000 in general. That's what they're going to ask you. Aspirin, 4,000 maximum a day, and Tylenol, acetaminophen, or paracetamol, that is the same, is less than 30. So aspirin don't give to a patient who has a viral infection and fever younger than 18 because they can lead into the Ray's syndrome. Ray's syndrome. Here, the Ray's syndrome. Okay, Ray's syndrome. So because they can lead into actually inflammation of the brain. All right, so here we have, if you don't give aspirin, but you instead you can give the acetaminophen. One thing you need to remember is the so aspirin is going to decrease the coagulation, correct? So if you take garlic, ginseng, ginger, ginkgo biloba, remember all the yeast, including green tea, for example, they are going to just increase the risk for bleeding. Open eyes, open ear with that, okay? All right, so salicylates. What is the difference between aspirin and salicylates? Salicylate, aspirin is the acetyl salicylic acid. Aspirin is the acetyl salicylic acid. And these are the salicylates. That is a precursor of the aspirin. the acetyl salicylic acid. Okay, though mostly they can be used as a cream. They can be as a combination. For example, Excedrin that used for migraines, Ecotrin that is an enteric coated aspirin. So they can lead in salicylate or aspirin toxic levels can lead into tinnitus. Okay, so those are the summary of the here. Look at this. Okay, we have Neurontin. Neurontin is a coadjuvant for painkillers. Okay, Neurontin is a gabapentin that is going to help for the control of the pain. Now we have the Tylenol. What is the antidote for intoxication for aspirin? There is none. There is none. For the antidote for Tylenol acetaminophen is the acetylcysteine. Okay, so all these guys, when you have too much aspirin or too much Tylenol, what is going to happen is hepatic necrosis or liver dysfunction, hepatotoxicity. Hepatic necrosis, death of the hepatic tissue. All right, so isothioneine. Isothioneine is the vitamin A. It's called the retinol. We have the carotenes. Remember carotenes? Carotenes are precursor of vitamin A. Carotenes are located in the carrot, for example. So everything that have that color as a fruit or vegetable, they have a lot of vitamin A. All right, so this is important because they use as a cream. They can produce increased redness of the skin, and be careful with women who are getting pregnant. If women get pregnant and they're taking isothioneine, for example, they have acne because it's being used for treatment of acne, they can actually produce fetal malformations. Fever feel. So open eyes, open ears here. That is used for migraine, menstrual cramps, okay, headaches, fever feel. Sunscreens, they need to be used at least 30 minutes before the exposure of the sun. Sulfamylone for burns. This sulfamylone produce a burning of the skin, so that is temporary. Ray's syndrome is going to produce by aspirin in minor level with acetaminophen and outdated tetracycline. So just remember at this moment, you can use this slide next in Pharmaco 2. It's going to be easy to remember. But at this moment, you know the aspirin-Reye syndrome etiology, cause of that. One thing I don't want to go without saying these differences, leukopenia, low levels of leukocytes, all the lines of white cells are down. Neutropenia, all the neutrophils are down. So neutropenias and leukopenia, sometimes they use as same thing. Granulocytopenia is this granules, cyto cells, penia means low. That is when you have, for example, the eosinophils, they have granules inside, or the neutrophils who have granules inside, or the basophils that have granules inside are going to be low. In conclusion, for NCLEX, for HESI, remember this, when just don't try to go back and forth between leukopenia, granulocytopenia, or neutropenia. Just consider everything the same. What? Low levels of white cells, period. Okay, so here we have, please, I want you to remember the magic tools. This is another in addition I put it in this webinar. So these magic tools are going to help you a lot. So please, we have the digitals, toxic levels more than 2. Lithium, more than 2. Phenytoin is coming in the next module, more than 20. Theophylline, more than 20. Vancomycin, more than 20. So just remember, so those are very high yield in NCLEX. So I just want to put it here and just keep it. And baclofen is a muscle relaxant that is a central nervous system depressant, and they are going to use for urinary retention. So constipation, urinary retention, and seizure threshold is diminished. So they need to increase the anticonvulsant medication, baclofen. So that is mostly coming for next module 2. Anyhow, so now I want just to review a few things just before we go. And please take note, this is important. I want you to review your nursing process, all the ADPI. So what does it mean, the evaluation of the medication? That means the monitoring, how you check the effectiveness of the medication. So nursing process. I want you to be careful with your medical errors. How the pill is given, what mistakes happen when you drop the pill or when you read the prescription wrong. The routes. Okay, I want you to review the routes. What is pharmacokinetics, pharmacodynamics? Okay, pharmacokinetics. So all how the pharmacokinetics is how the drug affect how the body affect the body, and pharmacodynamic, how the drug affect the body, right? So how pharmacodynamic, how the drug affect the body, and pharmacokinetics, how the body affects the drug. Okay. And we have OTCs. So there is a spread out of many questions in English about OTCs. One of the main things I want you to remember is that if you take OTC, for example, antacids for months, so what is going to happen? You can you can actually be hiding the signs and symptoms, and just remember, more than 2 weeks is your cut time. If you have 2 weeks gastritis and you continue with that, you need to go to the doctor immediately. I want you to know about the first pass effect. First pass effect. What is the bioavailability definition? Okay. First pass effect is when they pass through the gastric acid, right? So for example, do not have first pass effect if you have subcutaneous injection or intramuscular or sublingual or transdermal medication. Okay, so you just need to remember that. Drug abuse, we need to talk about the tolerance. Okay, the tolerance. Tolerance means that you need more and more drug to make the same effect, because the body create more receptors. It's not enough the previous dose, so they need to increase the dose in the next time. Rufis, you remember the Rufis for drug abuse is the flunitrazepam, the Rufis. We have when you have patients with alcohol, remember the what the anti-abuse disulfiram effect. Okay, anti-abuse or disulfiram effect is to keep the patient away from the alcohol. So if they smell or even drink alcohol, perfumes, mouthwash, whatever is alcohol somewhere, if they take this disulfiram, is going to have very, very bad vomiting, even rupture of the esophagus sometimes. So this patient with alcohol abuse, they can lead into psychosis that is called the Korsakoff, right? Korsakoff psychosis or Korsakoff dementia. And these patients with chronic alcohol or alcoholism, they have a deficit of vitamin B1, right? Remember vitamin B1, so that is need to given to the patient. So this vitamin B1 is part of the causes of this problem of dementia Korsakoff. Another thing, remember the pain, acute versus chronic pain. Vicodin, what is Vicodin? Vicodin is a combination of opioid plus NSAIDs. Vicodin, Percocet. Okay. So what are the side effects? Side effects are loosey, lightheadedness, urinary retention, constipation, and itchy. So those are the actually these side effects. Remember opioid side effects, number 1, 4, 5, 6, breathing, depression, number 2, constipation. Antidote is the Narcan or naloxone. Naltrexone is an antidote for opioid 2. Methadone. If you remember that methadone is an opioid and is given for withdrawal syndrome of opium. Methadone is opium, but it's less addictive. So that's why it's given as a initial treatment in order to start the treatment for opioid dependence. Okay, so here we have the acetaminophen. Acetaminophen 3,000 milligrams is the maximum dose. What it can lead hepatic necrosis. And you remember, please remember the antidote for aspirin is none. There is no antidote for aspirin. What is the antidote for acetaminophen? The acetylcysteine. Acetylcysteine. Acetylcysteine, if you remember, is a substance that is very bitter. So they need to take it with something that is sweet in order to be able to take it. All right, so just remember that dantrolene is for malignant hyperthermia. Don't get confused dantrolene with the naltrexone or Narcan or naloxone, please. Okay. All right, so anesthesia, we have a high risk, especially in patients who are obese and patients who are older. Remember the herbs, the feverfew is using for migraine. The antilipemics, we already talked about the niacin, garlic, ginger, right? So all these 4 guys are going to increase the activity of the warfarin. Statin is the atorvastatin is the HMCO inhibitor, right? That is going to decrease the production of cholesterol. Diuretics, when you're going to have any diuretic can produce orthostatic hypotension. You need to take it in the morning. You need to differentiate what is the potassium sparing diuretics versus the loop diuretics and the thiazides. You already know what is the main side effects of the electrolyte imbalance. Potassium, sodium. You know antivirals. The Zidovudine is for HIV, BMS, bone marrow suppression. Cyclovir, the topical is inhibit the topical is produce some burn on the skin that is transitory. Okay, so the interleukins produce the capillary leak syndrome. You already know the main side effects of the acid control medications. We talk about the antidiarrheal. You know the Pepto-Bismol has aspirin or acetylsalicylic, and they can produce dark stools and blue gums, right? All right. So I think that is about what I want to tell you today. I'm sorry, I just did it very fast. The just a moment. The slides. So I was trying just to make have a little more time, but I think I guess I did some good summary of what we have. All right, so I go into just a moment. Just a moment, please. I'm going to stop.